Good morning, everyone. I'm very aware it's this time, so I will try and keep it relatively interesting. I've steered away from being too focused on the stats and research specifically. I've kind of gone for more practical and experience-based discussion today, and I'm happy for questions and things later to see what people think, basically. That's what I said. I'm Natasha, and the team lead physiotherapist at OUH for predominantly the acute haematology and oncology ward. But I previously worked in a specialist role with the red cell team, where I said before I started to develop a pain management service there, which incorporates a lot of what I'm going to talk today as well. So apologies, it's just because of the cells, it should say red cells, PTE project. This is an old slide that I just adopted last night. So basically, I was very lucky, not long after starting here in 2019 in November, that the team at Oxford asked me to carry on doing a little bit of work and just save some money specifically for my role, so I could backfill it to achieve a project around fatigue, because you guys identified it as a major problem within this cohort of patients. It has been slightly waylaid by you-know-what, but I will get there, hopefully by the end of this year, and have something tangible to present. But actually today is also part of my just to tell you about it, and also give you hopefully a bit of information that could be useful to you in terms of managing fatigue and assessing for it. Let's just about that. So what is fatigue? I took this list of sort of definitions, you could call them, or suggestions from a summary nicely of evidence they put together. Basically, there is no universal definition for what fatigue is. They talk about things about sensation of exhaustion after usual activities, a lack of energy to participate in things that are quite usual in terms of work or leisure. Physical, it can be physical, it can be emotional, it can be a psychological symptom, and it's normally often not relieved by rest, and it can often be quite persistent. Where better to get a proper description than our actual patients? So as part of my project, I did some questionnaires, some of which, as clinicians, you might have seen. But these were some words that I got from the adult and the paediatric patients. And you can see there's one word that both sides said was very popular, which was tiredness. And there's other things around exhaustion, permanence, feeling heavy, lack of energy, extreme lack of concentration, life is a struggle, things like that. So really that's, again, just trying to put that narrative of the patient right at the heart of what we're talking about. But then if we're going to talk about what it actually is, what, just beyond the experience, beyond the definition, what is it that we will see as clinicians when people walk in? It's that physical tiredness or emotional or cognitive tiredness. So they may have lack of concentration, inability to think, foggy thoughts, generally low energy. They often can feel very overwhelmed. It can come on suddenly, maybe a change in circumstance, or it can be a gradual process that can take people by surprise. It's often disproportionate as well to the situation they're in. Something very simple, quite menial that would be thought of in normal life can feel quite different for people with fatigue. It's often unpredictable, and it can either be mild or severe, and people can interpret that and perceive that differently, obviously. And obviously that word exhaustion often comes alongside it. But why is this important? Well, obviously, it's the impact on quality of life. That's really why we're all here, isn't it? We want to make people's lives better. We want to try and get the most out of everybody's life, whether they're young or old or anywhere in the middle. You can talk about causes and what causes it, and I will come on to talk about that a little bit in a moment, but there's multiple things that can contribute towards fatigue. It's quite complex. It can be quite an unfamiliar experience to people, and it can cause a lot of disempowerment. So one of our roles is we can try and empower people better to try and get on with what they want to do, and it's surprisingly common. We obviously have quite a small group of people that we work with relative to the whole population. But actually, even in the general population, fatigue is quite a common experience because it features in a lot of long-term conditions. And again, I wanted to draw this back also not just to our patients, but to clinician experience. So I've just drawn this again from our questionnaire to put together, and hopefully some of these might even be people in the room thoughts if you filled it in. I'm not going to read them individually, it's a bit blurry, sorry. But basically the theme that came through, that the barriers to fatigue and knowing what it is and how to help people, is time, that ever elusive factor. The irony of discussing fatigue when people are coming at you with fatigue and sitting there looking exhausted. You feel that you have nothing to offer and feel powerless to help people, and that your knowledge and skills within this area feel limited. Hopefully, maybe less by the end of this, you know. In terms of the conclusions from the questionnaires, I just thought this was a useful thing. So this is probably the best thing I take that so far come out of my project, what I concluded from everyone's thoughts, which was the most patients, parents and clinicians have heard of fatigue. Well, that's a good start. Most patients, parents and clinicians would like more additional support and information around fatigue. Hopefully that justifies why you gave me the money in the first place. And then written information was the most popular resource. I guess it's because it's a tangible thing. People can take away, you can give out. But also then maybe followed up by a more modern sort of video-based resource, which hopefully may come to fruition at some point. And then it was also just that having a conversation about fatigue and providing some information will help. So I guess what I hope to take away from this is I'm not asking you to become an expert, but what maybe a little bit was where Sandy started in her talk just before. It's about the way you maybe approach it and what we can do with really small interventions to just get that process started. Because time, we're never going to give you more time. So it's about how you can use that time in a different way and have a different type of conversation maybe than you've had before. So causes, and a little bit with pain management as well. I have a difficult relationship with causality when it comes to things like fatigue, pain, the psychological issues as well, because you can't put a number on it, you can't draw a line smoothly from one thing to the other. There's too many factors. But I wanted to summarise, and a lot of these maybe fit more so, say, in sickle cell disease and other parts of the red cell disorders, but these are the common things that you probably will recognise that have contribute towards fatigue. It's vast, there's a lot to consider, but they can be very impactful. The things that aren't written there that are even more impactful, even the physical characteristics, are the sort of mood disorders, the anxiety, the stress, the depression, and then the other more complicated things that maybe underlie in some of our population. So being able to screen for mood, being able to have confidence in identifying some of the more psychological side of things can be really helpful. And I did realise that leads hopefully nicely into what Ian's going to talk about after lunch. And then basically we just need to try and optimise some of these things, but we'll come on to that later. So how are we going to assess this? This is the trickiest bit. This is the bit that probably takes the most time. But basically, what I wanted to bring across is that it's a holistic process. It takes time, but you can prioritise elements of it. So you're not necessarily going to hit everything I'm going to talk about in one session, but it's what can you draw out from someone? What comes naturally? What's the priority, I guess, to cover? So things like, what is the problem? What are they coming to you with? Is it that they're talking about weakness, reduced exercise tolerance? Are they talking about a lack of concentration or change in mood, low mood, swing in mood? Are they frustrated? Are they angry? What is it that they're telling you? Are they not able to do their basic leisure activities that were normal for them, or they've never been able to do them and they feel bad about that, or their work has changed and they can't do that anymore, or they've had a situation where they were working and now they're not working? What's the nature of the problem? So sometimes you have to tease out what that really means to someone and listen, you know, with what the words they're using, particularly around things like sleep and fatigue. The sleep can be quite a deceptive one. Is it that, you know, they have a sleep disturbance and there's something fundamental with their sleep that's the problem, or is it that the sleep is the outcome of the problem itself, if that makes sense? Is it motivation, or is it an intolerance to being able to do the activity? Because if it's motivation, you might say that that's more of a mood and psychological support need, or is it the fact that they can't tolerate it and actually then you're feeding other issues that maybe come up? Onset and cause, so listen for patterns. How are they describing things? One of the common things I talk about is boom and bust, this idea that people will do lots of activity and then they'll go through periods where they can't do anything at all, and that can be across an hour, a day, a week, a month, a year. And it's listening. The boom and bust is a key one, I find, because it basically means we're doing this. And in life, any of us who do this, you know, there's good times and bad times, but really what we all want to do is kind of do something in the middle, isn't it? Just listening out for things like that, because that can be a key thing that you can tap into very quickly to make a change. Also then, what's their understanding of the symptoms and the situation? What are their ideals? What are their beliefs? Can you identify things where modifying a belief or modifying something that they know will help them to achieve something better? So that's where kind of your education and information giving can be helpful, but also trying to work out what are the things people get stuck on that they probably can't modify their belief system very easily with. Maybe that's not the thing you tackle first. Maybe you can find a quick win somewhere else. But like what Sandy was saying, people are their own experts. So if there's something that they've done before in the story they're telling you, that, or you can hear something they've done before that they haven't realised that can help them in this situation, because that's gold. If you can set that up for somebody and make them realise that they've actually already got an answer to their problem, you've already done the job and you've only not spent any more time doing it. So that can be a really useful thing to think about as well. And also just reaffirm what sounds helpful, and in the past, and sort of give back that information to them, because whether it's a particular strategy or not, sometimes people get so caught up in it all, they don't know really what they're doing. And also sometimes people have tried to have treatment before. So again, that will tell you, is there something that they found helpful that they could repeat or have a refresher on that would help? Or have they already got a massive block because that just didn't work last time? And then again, you know from that assessment what you can kind of guide and use. Then a little bit like opening a can of worms sometimes, is thinking about the background of people. What's their social support like? Who can help them with all of this? It might not be, you might not be able to help them, but who can help them? Who could be the person they can talk through some of the things you bring up? What are their stressors that could contribute towards this? Who relies on them? You know, where are the kind of push and pull areas that can kind of contribute to some of these challenges? Just things to think about really is target those who probably have the biggest impact on quality of life. A lot of patients may have fatigue, but often they will dribble along and they'll kind of be all right. But we know time's precious, so maybe the people you need to target are the ones where it has the biggest impact, because that's where sort of the time is best spent in a way, maybe for your time anyway. And then it's really time consuming, as I've sort of mentioned. So you can acknowledge this with people, a bit like Sandy was saying, that don't be scared to bring it up, don't be scared to ask, but maybe just acknowledge what's achievable in that moment with that person, and maybe work out what you can then do beyond that, or who might be able to help them. There's a few ideas about who can be the most people to target. I guess it's those with the most complex disease often, with the high level of end organ damage, because as we go back to what causes it, those are the things that you might be able to optimise. And if you've done everything as medical professionals to kind of optimise that, then you know that the next thing is about managing the symptom rather than trying to cure the causes. Thinking about what pharmaceuticals they're on, is there anything that will also contribute to fatigue? And that basically this is very complicated, and it's about teasing it apart and seeing what you can do. So this is really the be all and end all, isn't it? Fatigue management. What do we mean by this? The only other thing I'll say actually is I haven't said about outcome measures. Through the research I've done with the project, there are some outcome measures there that have been used in sickle cell. Even though my job as a physio, often we're taught to use outcome measures and they're lovely and they make us see how wonderful we are as professionals and we've done a really great job. I barely ever use them in practice because they take time, they're not necessarily accurate, and it doesn't always mean something to the patient. So actually, if you've not got much time, I would say that it's not worth doing them. Others may disagree, but I think if you're just thinking about what you can do for that person in that moment, an outcome measure probably isn't really going to be the best use of time. I could speak for hours on all of these things, so I'm just going to try and run through a few key topics. So, first of all, planning. Organisation is key with fatigue. Being able to know what you need to get done and, you know, what the expectations are is a big part. The next thing that naturally comes on from this is what's the priority. I'll link this onto some tools that you can use to help with this, or people can do individually. Lots of people struggle to prioritise, and actually sometimes just sitting with them and working out what's most important, whether it's about fatigue or anything in their life, even just about medically what's the priority for them to focus on, can be really important. And again, this will link with further down the line with delegation as well. And then you've got pacing and energy conservation. So how fast they're performing tasks in their day, how they're doing them physically, what position are they in? Is standing up to wash up really challenging and exhaust them because they change the way they're doing it, because they sit down, because they break it up? What can they do to make individual things that waste a lot of energy or feel like they waste a lot of energy, that have low value to them as an individual, but they have to get done? How can you adapt them to make it better? And is there any equipment that you can use? Obviously, some of these things aren't yours to do necessarily, but I guess it's about hearing what the problems are and who could maybe help with stuff like this. And then you've got delegation. So can anyone else do the job they're talking about that they really hate and takes all that energy away? Yes, it might not be done to the same standard that they love to do it. And I guess it's about working out what's more of a problem for them, the fact that it's maybe not perfect, or the fact that they've managed to utilise energy in a different way. Now, I've quite deliberately called the next one activity. It originally said exercise and I changed it. For me, this is about moving more, being more active. Exercise in this group of patients has a lot of connotations. People really struggle with it. I've found in practice, whether it's through pain management or fatigue or any of the kind of quality of life aspects that you're trying to do better at, it's about grading whatever that activity or movement or exercise, whatever they define it as, and making it high value. We know as humans, moving more is better. I'm always going to say that. It really does. It does work. But it's hard. It's really hard. And when you feel awful all the time, it's even harder. So it's about making it high value, establishing what currently is possible, and then naturally grading it. Obviously, when you start looking at athletic level, that's much more complicated, and the professionals that do that. But I work with people that I'm on the lowest of the low level generally, and it is just piecing together what's of high value to them, what's most interesting, what are they actually going to do, and how can you help them to grade it into their lives and make it more realistic. The next one over again originally said relaxation. I changed it to restore, because for me, this is about identifying what restorative activities can you do that can help fill that jug back up for resilience, basically. Is it meditation? Is it mindfulness? Is it traditional relaxation? Is it active rest? So you can rest in different ways. You can rest your brain, you can rest your body. So, for example, you might have had to do something very physically active, but then could you sit and do some crossword puzzles with relaxation? Does it switch you off? Could you do some knitting? Could you watch some trashy television program or a film? What is helpful to that person? Is it a hot bath? Is it a massage? Is it listening to some music? What's restorative? And that's different to sleep. So for me, sleep is very specifically what you do at night, hopefully, rather than through the day, to actually give you that biological change to your psychology and your brain. Sleep hygiene is obviously the buzzword. I'm not going to talk you through sleep hygiene. You can Google it. There's some really great fact sheets around there that give you some really basic things that you can talk your patients through if you identify that as the key problem when you've done your assessment. But think about what's normal. They say you should turn off all your gadgets, half an hour before you go to sleep. That's good sleep hygiene. What makes me sleep really well? I fall asleep watching the telly in bed. Hold my hands up. That's not technically very good sleep hygiene. But actually, for me, it works. And I watch something that I've watched a million times, and just the noise, I fall asleep to the noise. And for some people, that's helpful. So it's not necessarily being rigid about it, but again, exploring what the helpful things and what the unhelpful things. And I really use different words. I don't use good and bad. I use helpful and unhelpful because the language is so important. And then finally, diet. I'm not going to go on and on about this. Everyone hates talking about diet. And I'm no dietitian, I can tell you that. But basically, my key things were small changes. Think about swinging diet. So people who go through sugar highs and sugar lows, we know that's not helpful because it can drive fatigue, it can make you feel sluggish and horrible. Can they swap to being, are they naturally a grazer? Are they a 3 meal a day person? Like what's normal to them, and maybe small changes and realities within that. Tools. So those things are the theories behind that underpin it, but then you've got to actually do these things. So what easy things can you do with patients in the moment that can be helpful? Because at the end of the day, this is about balance. We want to balance a mix of all of these things to try and create the best quality of life. And it's really focusing on what's going to be a quick win, what's going to be most helpful. The only thing I haven't put on here is fatigue diary, which feels really wrong. I should have remembered that last night at 5 o'clock, but anyway, I didn't. Fatigue diary is obviously one of the things, and that can help your assessment. Because say somebody comes in and they're telling you all this, and you've got 5 minutes. The fatigue diary isn't the answer, but what it can do is collate a selection of information that you can help them review at a later stage. If you don't have time to get into depth of it, sometimes talking them through how to use one can help you to help them later, or help them to help themselves later. So that's not on there, but that was the only thing I wrote down this morning that I remembered. Perfect. There you go. You can Google them. They're pretty simple, really. So the top left one is a prioritization square. So again, it helps people to order people's thoughts about what's most important to them. So what's urgent and really important, that's what they need to do first. What's important but not urgent, you schedule it. What's urgent but not important, can you delegate it to someone? And what's not urgent and not important, just don't do it. It is a really hard, letting go is a really hard thing to do. So it's easier said than done, but it's nothing joke about it. I'm going to go through it to the top right. So this was drilled into me from the moment I stepped into practice, but SMART goals. It feels like an obvious one. They're actually very tricky. But again, pick that one thing, make a SMART goal out of it, make it specific, make it so they can measure it. And I don't mean something clever with measuring. I mean, what's an easy way to show that it's been achieved? And how is it going to be? It's got to be achievable. So do you think it's realistic to complete this? If they say no, then you're not doing the right thing. And then timely, give them something to feed back on, make them accountable for it. How many of us need a personal trainer, need someone to nag them, even in normal life? Like, try and be that accountability for somebody, because often that's the hardest part. The bottom right is just sort of to say, it's about when you're looking at that restorative thing, what is it that, how can you identify what restore is most helpful to them? This is just the idea that mindful or being mindful. So if they're talking about having a busy head, not being able to switch off, something like mindfulness might be helpful. But if there's somebody who, it's not about a busy head, but actually, you know, they need quiet time, they need time away, maybe meditation's more helpful. Meditation is much more challenging to get into the place to do. So sometimes we have to work out which tool or which intervention is going to help them the most. The bottom left, I fully admit, I've stolen this off the internet. I couldn't tell you this from, it's very small. But I wanted the picture of it more than anything. So the spoon theory was created by a woman, and I can't remember her name, I'm afraid. But if you Google, I can't even remember, it's being long-term, if you Google spoon theory, it'll come up. It's basically been designed often off the back of lupus. But it's basically this woman who's designed something around people with long-term illnesses who struggle with fatigue. The idea is you've got 12 spoons a day. You've got a pot and there's 12 spoons in it. You've only got 12, you can only use 12. So how are you going to distribute your 12 spoons across the day for different activities? And then people can decide how much energy or how many spoons each activity takes. Now, for you or I, going to work, might be more like 3 spoons, because actually we're well, it's something we do every day and we've done for a long time, and maybe it's not a new job, so actually we have some level of ability to start with. Whereas for other people it might be 4 spoons, or if it's a job you've been doing for years and isn't very challenging to you, it might be 1 spoon. And people can categorise them basically. And then when you're talking about your prioritisation and your planning, you can then divide your spoons up and make a plan of the day. So if going to a hospital appointment, because it's stressful and a lot of energy, takes 4 spoons, well then you might want to balance out with things that are less than 4 spoons across the day. It's just a really nice way to sort of make a metaphor out of it. I'm almost done. So top tip, work out what's the most impactful problem on quality of life. Create a meaningful goal out of it and change one thing at a time. And don't change anything else until they've acquired that one thing, because if you do too many things, it just doesn't work. You can reflect and affirm what's going on. That's probably the biggest thing you can do for someone after having listened to them. And use those past experiences and strategies and make somebody accountable for what they're aiming to do, because again, that's the way our brains work. Referrals, this is really difficult. Everywhere has different access, but you may find the people with the most severe impacts on their quality of life and potentially their actual function every day, their local community physio or occupational therapy service could be well staffed to be able to help deal with this. How far up their priority list these patients get, I would not like to comment, but in theory, they do have the skills to support this. It may be that services have access to psychological medicine. Psychologists have got a lot of the behavioural management techniques and behavioural change techniques that can help to embed some of these changes that can help fatigue management or pain management. And then there's a little bit like our chronic pain management services, there are chronic fatigue services. So people who have long-standing complex fatigue issues, you may discuss and consider referral to a chronic fatigue service. But you have to just be careful with kind of the sort of diagnosis element of that, I know. So that was just a bit of a sideline idea. I think that was everything. Is there any questions or comments?